Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Paul Kim from California Orthopedics and Spine, California, United States. After his medical education at the Wayne State University School of Medicine in Detroit, Michigan, Dr. Kim pursued his orthopedic residency at the University of Washington in Seattle. Subsequently, he did a fellowship in foot and ankle surgery at the Hospital for Special Surgery in New York. He has won several awards, including the American Orthopedic Foot and Ankle Society Resident Scholar Award and the Wayne State University Award. So today it's my great honor to introduce you to Dr. Paul Kim from California Orthopedics and Spine, California, United States. Over to you, Paul.
Well, thank you for allowing me to speak about this topic today. It's a new, interesting topic, and please, I hope that this is entertaining and it gives you a different perspective on bunion surgery. I also have on my website, drpaulkim.org, a lot of patient outcome stories about the different types of minimally invasive surgery I perform. So let's begin. So this is an interesting paper that came out of Saltzman in Utah. It was talking about the unfavorable outcomes following surgical treatment of hallux valgus deformity. It was a systematic review. And as you can see, the prevalence is pretty high in terms of hallux valgus deformity. So in the average population, about 23% of the general population will have some form of hallux valgus deformity. And people over the age of 65 will have a higher prevalence of 36%. This is important because, as you'll know, that hallux valgus deformity is not a static deformity. It's a progressive deformity that gets worse over time. And in their study of the different procedures, the most common procedure that was performed was the distal osteotomy. And if you look at the distal osteotomies, the dissatisfaction rate was about 9.5%, which is quite high. Overall, patient dissatisfaction with hallux valgus surgery was 11%. And this is an important number. Recurrence was 5%, which is, 5% is a true number. Even in my hands, I would say about 5% of my hallux valgus deformities did recur. So when you think about bunion surgery, there's a typical drawback. Typically, these procedures are performed open. You have to be non-weight bearing for 6 weeks or more, and recovery is about 6 to 12 months. That's a pretty hard sell when you're talking about hallux valgus correction to surgical patients. They have intense postoperative pain. There's a lot of stiffness because when you do that capsulotomy and you're doing the McBride, shortening the medial capsule, you get a lot of arthrofibrosis. And of course, the deformity recurrence, as we said in that paper, is about 5%. And you have large surgical scars. Large surgical scars equate to more dissection, equate to more possible risk of injury to the nerves, tendons, vessels, etc. These are actually quotes from my patients that had the typical open surgery. They would tell me, this is the most pain I've ever experienced in my life. And they would say, I even gave childbirth and nothing even compares. I have family and friends who have bunion surgery tell me never to get it because it's so painful and the recovery is so long. So when you look at bunion surgery, you're like, long recovery and pain, intense pain. So when you talk about bunion surgery, there's so many procedures to choose from. There's over 100 if you look at the literature. So how do you really choose a right bunion procedure? Well, the tried and true for me used to be a lapidus. A lapidus, so if you look on the slide with the red markings, those are the typical surgical incisions I would make for my lapidus. 3 really long incisions, a lot of dissection. You're fusing the first TMT. You're not weight bearing for at least 6 weeks, another 6 weeks to learn how to walk. I tell these patients, look, it's a year-long recovery. And even then, if you look at the patient's foot, they still have a slight deformity, a slight bump on their metatarsal head. So then I thought to myself, there has to be a better way. And so about 2 years ago, I started looking into more MIS procedures, and I would say that this drastically has changed my approach to bunion. So why MIS bunion surgery, you ask? Well, this is a recent article by Dr. Lewis over in the UK. It's a 2-year follow-up of the MICA procedure. And what they found is that social interaction, which was interesting that they try to measure that, social interaction and pain scores all improved. Their deformity correction was great. Their IM angle went from 15 to 6 degrees. Their hallux valgus angle went from 33 to 9 degrees. They had some neuropraxia, less than 1, but look at this number. It was less than 1% recurrence in 2 years. Now, you could say this is just a midterm study. Maybe over time, there's gonna be more recurrences, but I agree, in my hands, over the 2 years I've been doing this procedure, I've had 0 recurrences. So let's look at the pros of why MI surgery. Why? What's the whole point of it? Just because it's smaller incisions, because it's new fat? Well, there's a lot of pros. It's a faster recovery. I actually get my patients to walk in about 2 to 4 weeks. I get them back to being active in about 6 weeks. There's minimal surgical scars. There's only 4 small incisions. Optimal results. I mean, we're talking about a triplane deformity. We'll go over the surgical procedure a little bit, but it's basically correcting it in all 3 planes. There's less complications, low risk of non-union, infection, and less recurrence, as we saw. It's quick surgery. The surgery, once you become good at it, it can be 30 to 45 minutes. I would say now my surgeons are down about 20 to 25 minutes for this. All in all, it's a very high patient satisfaction. When I did my Lapidus procedures, I would ask my patients, hey, what is the likelihood you would recommend this procedure? And they probably say no. But the key thing is for Lapidus, I would say I barely would get patients to come back and do the other side. With my minimally invasive, it's pretty common that they'll come back and do the other side, or they'll want it done at the same time. So let's look at the cons. I mean, with a new technique, you got to be a little skeptical and say, okay, I can't just jump into everything. I want to look at the complications of this. So it is a high learning curve. I would say on average, you'll probably need about 15 cases to learn. It's not currently really taught in residency worldwide. I think it's catching steam, but not quite yet. In residency, I never even heard about MIS for bunions. It's a small surgical incision. You got to watch out for trauma to the dorsal medial cutaneous nerve, and it can cause thermal necrosis. So it's very important to use irrigation when using the MIS burr. Hardware prominence. So they are coming out with newer screws because typically the screws that you leave that we use now have a little bit of prominence. There are some industry companies that make these beveled screws. So those are that's basically getting rid of this hardware prominence problem. Malunion, non-union, it can easily happen. You can dorsal or plantar flex. It's all really technique driven. There's this thing about hypermobility. I know that some people believe in and some people don't. To be honest, you can actually correct a little bit of this hypermobility by plantar flexing the distal capital fragment. And shortening, the burr will take about 2 millimeters off of the first metatarsal, causing possible transfer metatarsalgia. But that's with anything. I mean, even if you use a saw cut to, for example, a Lapidus, you're going to cause some shortening. But all in all, I would say the pros definitely outweigh the cons. So let's just talk about some cases here. So this is a patient of mine. She had a hallux valgus deformity, and I thought she'd be a great candidate. So those 4 lines are the actual true incisions for this procedure. As you can see, she has great correction of her IM angle and hallux valgus angle. Her sesamoids are nicely reduced under the first metatarsal. And this is her year out. And people say, well, is it going to remodel? And it definitely does remodel. And so this is her foot. This is a 1 year out from surgery. If you really look at it, you can see kind of where the surgical scars are, but she has a nice aesthetic result, very happy. She has no arthrofibrosis, back to full activity. So yeah, she's very happy with her bunion surgery. And you look at this, well, okay, so this is how the cut is actually made. This is a little bit earlier on, so you can actually see where the cut is made in the metatarsal. Again, she has nice reduction of her IM angle. She has a nice reduction of her hallux valgus angle, and the sesamoids are nicely reduced. And truth be told, that osteotomy always does heal. And so what does this look like more acutely? So this is her pre-operatively, and this is her at, I think this is at about a month out from surgery. As you can see, the surgical scars are still healing, but now you can see her foot is still edematous, but in terms of the correction and aesthetics, it looks great. And this is her walking at that month out from surgery when I took this picture. So you can see that she's walking pretty pain-free. Now she's not back to running per se, but she is back to doing things such as riding her bike. And then this is only 2 weeks later at 6 weeks. So that 2 week, I would say most people make a huge jump from that 4-week recovery to 6-week recovery. And even here, you can see her walking on her tippy toes without any problems at all. So after this visit, then she is pretty much cleared to do whatever she wants. Here's another case. So again, hallux valgus correction. She is an interesting patient. She came to me for a second opinion, and the prior surgeon told her, hey, it's going to be 6 weeks of non-weight bearing, 6 weeks of pretty much learning how to walk, and overall 3 to 6 month recovery. And she had bilateral bunions, and she came to me and she's like, oh, that sounds ridiculous. I need a faster recovery because I want both done. And so we decided to proceed with the MIS surgery. And as you can see on the left-hand side, she has a nice correction. The sesamoids are nicely reduced. And the medial eminence, how when we do bunion surgery, we shave that medial eminence off. A lot of the times when you translate it and you derotate the capital fragments, that medial eminence goes away because, as you know, this is a triplane deformity. So when you correct that rotational deformity by getting rid of that overpronation, that tends to get rid of that medial eminence. And sometimes you actually don't have to do anything. And so you can see it when she wore the pink sweatshirt, that's her 2 weeks after surgery. She's, of course, walking with antalgia. You know, she's walking what we call flat foot weight bearing. And then even 2 weeks later, this is her with sneakers on. And yeah, her foot's still edematous and swollen. You can still see that she's walking a little bit more gingerly. And again, that 2 week, 4 to 6 weeks is when they make that big jump. And this is her at 6 weeks. So again, her foot is still edematous, but in terms of her results, she has no pain. The only complaint that she has is she doesn't like the scar. She feels like the scar is a little ugly. She wants it to be a little more aesthetic. But other than that, she's very happy. So after we took this video, she actually signed up for her other foot. Now, MIS can also be used not just for primary hallux valgus, but it can be also used for different procedures. So this is an interesting patient. She had, I'm assuming some kind of plantar plate repair by someone else, had a very, very stiff second toe, pain everywhere, could not walk. And so she had gone to different providers, given different opinions. And I told her, I said, well, one, you know, you would say, well, she doesn't really have a bunion. I'll show you the picture of her foot, but it wasn't really to correct a hallux or valgus deformity. It was really to correct more of a rotational deformity. Also, I wanted to plantar flexor capital fracture just a touch. Also, what we did was a distal metatarsal osteotomy using a percutaneous approach. So these instances, it's like a wild osteotomy, but you're doing it percutaneously, and you cut all of the metatarsals at the proximal metadaphyseal junction outside the capsular structures. And once you break them, you just actually allow them to walk, and these kind of find their place and they're happy. So that takes care of a lot of the metatarsalgia that these patients have. And so this is her after surgery. As you can see, her foot looks quite deformed on the left. And you would say, well, she didn't really have a bunion to begin with, but now she really doesn't have a bunion. And basically this case was to correct the rotational deformity. And you can see those stab incisions on the dorsal aspect of the foot where I made the distal metatarsal osteotomy. And this is her 2 months. And she is walking a little gingerly, but I'll tell you, it's not because of her foot. It's actually because of her back, because she had such a bad foot for so many years that her back started becoming an issue. And she has, sciatica. And so that's why she's walking gingerly. But if you ask her now if she loves her foot is pain-free, now she can focus on her back, which actually was caused by her failed prior foot surgery. And so, like I mentioned in the beginning, these are one of the procedures that you can do this bilaterally. So here's a patient of mine. We did bilateral MIS bunions. I want to draw your attention to the first metatarsal phalangeal joint. If you look at it, you would say she has some arthritis preoperatively. But look, once you do the osteotomy, you translate it, you derotate it. Look how nice and symmetric the first metatarsal phalangeal joint is. Look at that articular surface. I didn't do anything. All I did was translate and derotate. And you can see that once you do that, it actually helped. This is why these become painful, because they will lead to arthritis. In her instance, it was not the deformity itself, but it was the fact that she was developing arthritis that was causing a lot of pain. This is her preoperatively, and this is her at 6 weeks postoperatively. Again, quite edematous, but nice deformity correction. And she is walking pain-free at 6 weeks. Again, this is another one of my patients, really bad feet problems. She has scoliosis, so it's actually her back. Her feet don't bother her, but she's like, this is great. Now, whenever you do bilateral surgery, I do tell people the recovery is not so streamlined. You might have about a 2 to 3 week delay compared to doing a unilateral approach. And with MIS surgery, you can actually start combining these with other procedures because, again, it's quick procedure. Once you get fast at it, it's pretty easy to do. Here's a patient of mine. Now, her bunion didn't hurt, but the reason she wanted surgery was because of her third interspace Morton's and Roma. And that, if you look at the bottom of her foot, you can see that she has some calluses on the second and third. Her big toe is pronated. I told her, if we're going to do this, we need to recreate that triplane structure of the foot. And that's why I would recommend going with an MIS bunion surgery. And she agreed. And so this is her at 6 weeks. We took out the Morton's and Roma, corrected her bunion, and she is back to walking 1 mile per day at 6 weeks. And remember in the beginning, I told you that this does limit arthrofibrosis because you don't do any kind of capsular surgery. And this is removing her toe. I mean, yes, she's a demodex, but she has no pain. She has great range of motion and minimal surgical scars. And she's back to walking 1 mile per day at 6 weeks after surgery, which is amazing. And I wanted to finish with this because this is a pretty unique case. Now, you know, MIS can be taken for really, really extreme bunion deformity. And in this case, this is probably the worst bunion deformity I did. Unique case, very, very bad hallux valgus deformity. However, her pain was actually at the second and third metatarsal phalangeal joint. It was not really the hallux valgus deformity. So we talked to her about doing a Clayton Hoffman. We talked to her about fusion the first, second, and third MTP. We talked about all these different options, and she sought some different providers. But in the end, I told, hey, we can try this more minimally invasive approach, faster recover. If it fails, we can proceed with the next procedures. And she decided, let's try the minimally invasive. So we first started with the right. The right, we just did a minimally invasive, and I did the DMO of the second and third only. As you can see, the pictures are pre and post op. Her deformity still looks like her foot doesn't look that great. You're like, well, why? This surgery is not a success. It failed. But you know what? It's about patient outcomes. This is her walking 3 months after bilateral minimally invasive bunion surgery and the DMO. Now, you got to understand, when I first saw this lady, she was walking with a cane. She could barely walk. Every single step hurt. She's back to playing tennis. She's like, I can't remember the last time I played tennis because my feet feel so great. Now, she still does use these silicone bunion spacers, but in this case, this wasn't aesthetic. This is about function. So she's back to being functional, and she's very happy. And again, this was about overall, it was a total of 6 months to do both feet and recover. But again, if we would have done both, she'd still be in recovery. So it's great. So if you look at the post-op schedule for the minimally invasive bunion surgery, I put them in a cam boot or a post-op shoe, and I tell them to heel weight bear for 2 weeks. And then after 2 to 4 weeks, they can weight bear as tolerated in a cam boot or a post-op shoe. And at 4 weeks is when I transition them into athletic shoes. And then after 6 weeks, I graduate them back to their pre-surgical activities. So in conclusion, I think minimally invasive surgery works well. It's less invasive. It's a faster recovery than typical open procedures. You can actually do these procedures bilaterally. There's a lower complication rate and a higher patient satisfaction. Overall, it is a game-changing procedure for bunion treatment. Thank you very much for allowing me to share.
Thank you, Paul, for your fantastic and a brief approach to MIS for bunion correction. Couple of questions, Paul.
Yeah.
And there is no doubt that MIS is going to be accepted as one of the surgeries for foot surgery. What do you think a resident need to do? For example, if he's in a foot and ankle surgery training, do you think he can start away straight with MIS, or do you think he needs to do a lot of conventional open bunion surgeries before taking up MIS?
Yeah, so good question. So in terms of how I got into MIS, I think I'll share my technique. So I didn't jump into doing MIS bunion surgery. I used the burr because it's an actual burr that has a pedal. So what I used the MIS burr for was to joint prep. So if I was going to do a fusion of some sort, that way I can see how the burr works in my hands and I can get a use for that. And then I would start doing it for like smaller osteotomies, like an Aiken osteotomy, and just seeing how percutaneously it works. And then I would, go from there. The companies actually do have a lot of cadaver labs. And so I think if the residents are interested, they should start reaching out to the local reps. The two companies that I know that do it prominently are Right Medical and Arthrex. And if you tell, hey, we want to get a bunch of residents together, we want to go into the lab, and we want to practice this, then I think they would be more into tune doing that. As well as when you're in first practice, you can do that too. There's a lot of courses that teach about MIS now.
Thank you, Paul, for that. And regarding the specific surgical technique, you mentioned about derotating the capital fragment, right? So which is the direction? So the forefoot is actually in pronation, right? So you need to supine it, which direction?
Yeah, so you translate it and then you derotate it. So basically, the way you gauge it is you want the toenail matching the second toenail. So basically straight up. That's how you're kind of gauging that correction.
Okay, got it. And do you think only the chevron and the Aiken are the ones that are amenable to MIS, or do you think the other osteotomies like scarf or something like that can be done using MIS?
I think it would be a little challenging to do, for example, a scarf, because you have to make that Z osteotomy. I actually don't do the chevron. I use just a transverse cut. The main reason is because with the chevron, you can't do a triplane correction. You can't derotate it. So that's my bias of doing that. I know of a surgeon, I think in Canada, that is actually doing a MIS / arthroscopic assistance lapidus procedure. There are other types of MIS surgery. There's like this company called Crossroads, and there's like a thing called Lapiplasty. So there's different companies that are doing it. I just like the whole easy transverse cut, derotate, put 2 screws in.
So you just, your primary aim is to translation, derotate, right?
Correct, yes.
Just these 2 important steps and you're through.
Yeah, because if you look at, there was an article talking about recurrence, and I didn't include that in my talk, but it's actually the sesamoid positioning that will be the hallmark of will these recur. So if you get the sesamoids nicely reduced, that will tell you if these are going to recur or not. And in this case, if the sesamoids are well reduced, they're not going to recur.
And just a technical question, you are mentioning about translation, and how much overlap do you expect? Like, what is the maximum overlap?
I actually sometimes do 100%. That sounds crazy. Like, oh my God, there's like no bone apposition. Is it going to heal? And they do heal. So I would say in my hands, I've actually not had a non-union. Now, I'm sure it'll occur sometime, but so far I would say I'm close to doing over 100 of these and haven't had a non-union so far.
And just one last question before we wind up the session. What were your complications in the initial period before you started doing in the initial first 20 cases of your MIS bunion correction?
Yeah, so it's when I started this, even the company that makes the burr that I was using didn't really even have a protocol because it's so new. And so the thing with that, they're like, what's so special about this whole MIS burr anyway? The burr is a high torque, low speed system. So it doesn't wrap up tissue. So when you're doing this initially, you just have to understand that. And for me, I put my RPM value about 6,000 because these can go up to like 20, 30, right? So I keep it at 6,000, and it's all the techniques. So when you hear it, you actually can audibly hear it cutting the bone. If you don't hear it, then you got to stop. You got to pull the burr back. So these little things that you can learn from technique guides. Also, the proximal incision where I put my 2 screws in, that's where you're going to capture your dorsal medial cutaneous nerve. So simple things: make the incision a little bigger, put a little rag nail and pull that up so you don't get that nerve. And so these little things are how you're going to avoid, because again, you can capture the dorsal medial cutaneous nerve, you can capture the extensor or flexor tendons, you can basically cut the second metatarsal. So these little things that you got to kind of watch out for. But as long as you're careful and if you give yourself time, I would say the complications are less. So you just got to be mindful of how you're doing it. One thing I didn't show you in this slide is how to position these patients. So it is a weird positioning because their leg is actually floating off the end of the table.
Okay. Thank you, Paul. I think that's all the questions that we have for this session. Fantastic lecture. And I'm sure this lecture is going to benefit a lot of people all over the world. Thank you, Paul, for joining.
Thank you very much.